nurse here at St. Francis. I'm also a current student at Columbus State University in the RN to BSN program, and I'd like to thank you for coming out to review my Capstone Project today. Thank Babs McKnight, being my preceptor, for getting me through this process so that we can review how we can reduce the 30-day readmission rate for patients that suffer with chronic obstructive pulmonary disease, or COPD as we know it. So COPD, like I said, is a chronic progressive disease that there is no cure for. And what I've learned during this project is that it's a leading cause for admissions. It's also a leading cause of readmissions. And sometimes for those discharges, for patients that suffer with COPD, there's a delay in that discharge. Can anybody here think of a reason why there might be a delay?
We don't have things ready for them. They don't have family to take care of them.
Don't have family to take care of them?
They need to have what they need to breathe.
They need to breathe? I think that's a
do
problem.
well as
What
fast
could
as
help
they can.
them to breathe?
Oxygen, maybe they need equipment.
Equipment. Oxygen. Is oxygen equipment? Is it equipment? Or is it a medication?
Both.
Both.
Do we have to get approval for that?
Yes.
Absolutely.
Okay. So what could be a delay in that discharge for the patient with COPD?
We don't have our prescription, don't have it all what it needs in order to get them qualified to get
Has
their
anybody
oxygen.
in here run into that before?
Absolutely.
Okay, so I'm not alone. So an example of a delay in discharge could be that the patient has been on oxygen. We're ready to discharge them medically, they're stable, except they still have oxygen. So we're going to review that. So we discussed about COPD causing a problem with breathing. And so eventually they call 911, or they get family members to bring them to the hospital. Frequently that happens within 30 days of a discharge for the same condition. And that's why people that suffer with this has been added to the readmission reduction program with Medicare, Medicaid, if it's been less than 30 days since they have been discharged. So why is this important for the hospital? We know why it's important for the patient, right? Because they have a need to breathe. They come back because they can't breathe. So with the hospital readmission reduction program, there's going to be a loss in the reimbursement for services provided for these patients with COPD if we don't maintain a lower percentage rate of patients that return within that 30-day period. So how can we make this loss a profit? Make everybody happy? We're going to benefit the patient by providing quality health care. That's the full interdisciplinary team. Do y'all know who that might include?
Nurses.
Nurses.
Physician.
Yeah.
Case managers.
Respiratory.
Respiratory, yeah.
Patient and family.
Everybody.
Physical therapy.
It takes everybody. Physical therapy. that's
Technicians.
right.
That's it.
This is going to increase accountability of the full healthcare team. And it's going to reduce the healthcare cost because we're going to get full reimbursement and not face a reduction in what we get paid. Okay? So with this program, I have found that we need to make sure that we're covering the readmission rate for patients with COPD. By doing that, we're going to need to educate the nurses who provide the care, the physicians, the full team that we just discussed, and design and implement a standardized DWO form. The DWO is a detailed work order. That's how we get the oxygen for the patient. At the present time, each of the durable medical equipment companies that are local have their own version of this form. So case management is hurrying, trying to find the forms that are required, and then having to find the physicians to sign the forms. And so we came up with a plan to design a standardized form that all of the local DME companies will accept. So let's go back to the patient. The patient that has COPD, what brings them to the hospital is an acute exacerbation of that COPD or AECOPD. Frequently, they come back to the hospital. We've already got that established. And they come back because they have shortness of breath or dyspnea and decreased oxygen saturation. One of the major factors that influence this readmission rate is that the disease duration is progressive. It continues to get worse with each of the admissions as the lungs continue to not be quite as healthy. And then another issue that we found is that if their oxygen saturation is less than 88% on room air, they are really struggling. So we're going to talk about that 88. So I was taking all of these ideas and I had to come up with a PICO question. Anybody know what a PICO question is? Anybody? Nobody knows what a PICO question is. So a PICO question is how we design a plan to look up literature that is evidence-based so that we can apply it to our plan to reduce this 30-day readmission rate. So PICO, P, the P stands for the people. Can y'all read that and tell me what my P stands for? Now let me read it with you. For hospitalized patients with COPD, does the initiation of home oxygen at discharge decrease the readmission rate within 30 days compared to those discharged without home oxygen? Okay, so again, what does my P stand for? People.
Patients.
Patients
Hospitalized
with
COPD.
COPD. And my I stands for the intervention. Here, what is my intervention?
Oxygen.
Oxygen. Because it's important to breathe, right? My C stands for comparison. What am I comparing?
Those discharged
The
without
outcomes,
home
yeah.
oxygen.
Yep,
Versus those discharged with
with
oxygen.
it. There you go, David. And so my O is my outcome. Good. And so I added a T. So it's a peacock question. So my T stands for time. What is my time?
30
30
days.
days.
Yeah, we need a measurable goal. And so we're going to base this on that 30-day readmission rate because we're going to lose money if we don't keep that percentage rate low enough. All right. So, what is my evidence for change? You have to have evidence. And you have to apply that to your evidence-based practice. So my evidence starts with CMS or Medicare that's already said they're going to decrease our reimbursement by 3% for those diagnosed with COPD if the readmission rate remains above a certain percentage. Right now at St. Francis, we are right below that percentage, right below it. If we go above it for the next year, they're going to reduce our reimbursement rate for all patients with COPD by 3% for the next year. So we want to be proactive and go ahead and consider the evidence-based practice and start practicing that way to take better care of our patients, to provide quality health care for this patient group. There was a study done that found that the mean average age of patients with COPD is 66.9 years of age. So at what age do you develop, at what age are you eligible for Medicare? 65. So they fall within that group. There's some evidence. COPD treatment is deemed a failure if that patient returns within a 30-day period. That's what Medicare bases their decision on for adding COPD to one of the diagnoses that they're going to reduce this by 3%. Also, in a 24-month study, there were 256 reoccurrences of COPD within that 24-month period out of 115 patients. That means that that there were 2 or more readmissions for each of those patients. So, found 3 needs that we need to focus on for this evidence of change. We need to reduce the readmission rate for COPD, increase the knowledge of all staff, and then also design this standardized DWO form so that we can obtain oxygen in a timely manner. So this is going to provide quality health care. It's going to provide education for our staff to include nurses, physicians, therapists. And the evidence is that there is a lack of knowledge for some things that we're going to discuss shortly. And then the standardized DWO is going to help stop the fragmented care that's provided for patients with COPD. So the key to all of this is knowing how to assess our patients. Knowing what the indication is of somebody that is suffering with COPD to a point that they are going to need home oxygen prior to discharge. And the need for the home oxygen. So what are the qualifications? What is the criteria that has to be met in order to obtain this oxygen, which is a medication that has to have a physician's order? So the key is finding out, does the patient desat to 88% or less on room air? If so, they qualify for oxygen. If they do not desat at rest on room air, then we need to ambulate that patient. And what do we call that here?
Road test.
A road test. So we need to ambulate that patient without oxygen. If during that time that they're road testing or they're ambulating down around the hallway, if they desat to 88% or less and they improve with oxygen once it's initiated when you get back to the room, then they qualify. They still qualify for oxygen. There is another way to do it that's a little bit harder that we don't do here very often, and that's being on room air while they're asleep. This is where respiratory therapy might come in and help us. So if they desat for 5 minutes or longer, and it doesn't even have to be consecutive 5 minutes, to 88% or less, they would qualify for oxygen. So these are 3 areas that we need to be focusing on for our patient to provide quality health care for those that suffer with COPD. Now, you do have a printout of the DWO. This is just a preliminary form that there are a few things that need to be upgraded on it. It's going to reduce the workload of case management. So this can be developed and is being developed by Cerner at this time. So with this, the patient education needs to be simple and direct. We need to have an educational packet designed very shortly for the patient. But first, the nurse has to be educated on this. They have to help design this. And then we're going to take that information sheet and educate our patient. We're going to get some teach back so that we know that the patient understands when they're at home within that 30-day period after discharge, when it's a good day, what they should be doing, when it's not so good and what they should be doing, and then when it's a really bad day, how they're going to handle their medical treatment at home. Y'all remember, this is a chronic, progressive, debilitating disease that we have to have good education and home oxygen to keep the patient out of the hospital during that 30-day readmission time so that we can maintain a profit and not a loss for our hospital that we're working for, that we're a part of. And so a change that needs to be made on that DWO is that we need the diagnosis codes to be added. We are working on that. These changes are going to promote better health care, it's going to reduce frequent readmissions, and improve the outcome for the patients. So, to evaluate what we've done, it's going to be based on the effectiveness of this plan. And the plan would be to have all of staff, including all of the interdisciplinary team that we talked about earlier, physicians, nurses, respiratory therapy, physical therapy, the patient. Everybody needs to be educated. Nurses to be the first ones within the next 2 weeks. The patients will be evaluated at least 24 hours prior to discharge for their need for home oxygen, following the steps that we talked about earlier. And then a monthly monitor of the readmission rate for patients with COPD. By doing this, we're going to reduce the risk of patients to be readmitted within this 30-day period with COPD. The staff will verbalize understanding. The standardized DWO is going to improve the process of obtaining oxygen in a timely manner. It's going to decrease the amount of delays in discharge. It's going to help us not to seem so fragmented with our care. And Cerner is going to provide that power form that's going to give us what we need to get the patients with their oxygen in a timely manner. So in conclusion, with evidence-based practice, we have the problem linked to the interventions, the outcome, and in general, we are going to be reducing that 30-day readmission rate for patients that suffer with COPD by providing quality health care, treatment in a timely manner, discharge after everybody has been educated, and there's a plan to take care of the COPD at home with the good, not so good, and really bad days without having to come back to the hospital. Thank y'all so much for coming. Does anybody have any questions?